Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Dennis Hursh, healthcare attorney. Today's Kevin MD article is wRVU, and that's Work Relative Value Unit, Threshold Risks in Physician Contracts. Dennis, welcome back to the show.
Thanks, Kevin. It's great to be here.
All right, so tell us what your latest article is about.
Well, I've run into more and more contracts now where the employer gives the physician a salary, but it's dependent on a certain number of wRVUs. And a lot of issues come up with that. I mentioned in my article, one of the first ones is doesn't mean anything. I'm seeing some now that say we pay you this salary considering or assuming you are going to work so many wRVUs, and that's it. So if you don't work the wRVUs, there's nothing in the agreement that says we'll take back money. So first you have to just see, is it just a meaningless clause in there? What I think they do sometimes is they set it up and then they say at renewal, hey, the assumption was you would do this many wRVUs. You didn't. So now we're going to reduce your salary.
Mhm.
But in effect, you have to look at just what is the effect of that provision. The biggest thing I think you have to look at is it a reasonable threshold? If you've been there for a few years, we know what your wRVU production is. There's no reason why, if you've been producing 6,000 wRVUs a year, that we would come in with a contract that says your minimum is 8,000. There's no reason to believe that you're going to hit that this year if you haven't in previous years. So obviously you can look at benchmarks, but your own history is probably even a better guide. And there's a few, I think, things to be aware of there. If you're just starting your practice, you shouldn't be expected to be super productive. If they just hired the new physician, that physician's going to take some time to ramp up a practice, should have a guaranteed salary for at least a year
Mhm.
and a lot of times 2 years, 3 years. And then another thing I see that just makes me nuts is I see where they give you a median salary for your specialty in this location, and it's dependent upon you doing the 60th percentile of productivity. I mean, there's a mismatch there. If they want to pay you at the 60th percentile, it's probably reasonable to expect 60th percentile productivity. But I see these really mismatches all the time where the salary's here and the threshold is
Mhm.
here. There's sort of this gray area in there where you're getting really working harder than what you're being paid for, but you're not being compensated. Another issue that is very important is you ought to be able to confirm it. I actually had a physician, a specialist, working really hard, seeing patients, full schedule, and they came in and they were actually going to fire him. It wasn't a reduction in salary, they were going to fire him because he was so unproductive. And his contract didn't give him the right to audit, but we finally talked to the administrator and they were showing him as having like two patients a day. And
Mhm.
he, like I said, he had a full schedule. I don't know if they were mixing up provider numbers, what they were doing, but this was a fully engaged, very busy physician. And again, the numbers they were showing showed him seeing about two or three patients a day. So it's important that you be able to confirm it. And then I think the last thing you have to worry about is when it's credited. Makes sense to me if you see a patient today, that today you'll be credited for the wRVU. A lot of contracts don't use date of service, they use the date of billing. And I've had instances where a hospital billing staff got short. You can't blame them. If you're the CEO, do you want your billing staff sending out the bills for the $900,000 ICU or the physician office visit that just there? So it's a reasonable business decision to put off billing. But I've actually had physicians that have lost bonuses because something screwed up. They were busy, but their wRVUs weren't billed.
Mhm.
So as far as their contract said, they weren't being productive.
So, before asking some questions, for those who aren't familiar with the intricacies of physician contracts, just give us a 30-second primer of what a wRVU is and how that factors into most physician contracts.
Well, to say most might be a stretch, but it's important. A wRVU is a work relative value unit, and CMS, the government, in looking at how to pay physicians, has done a lot of studies, And the concept of a wRVU is that it represents the work you've done. Some of it is a little when you're talking about they prefer procedures over thinking, so you tend to get more wRVUs for a procedure than even a very difficult patient that you're trying to piece through what's going on. But in general, the concept is a wRVU represents a certain amount of work. So, a complex cardiothoracic surgery is a whole lot of wRVUs. A level one office visit is going to be significantly less. But that's the concept. It shows how much work you're doing or how productive you're being. It is in a hospital situation, it's not actually a bad way to do. If you think about it, if you did collections, then you would be penalized if you were seeing Medicaid, patients or uninsured. This means at least you're getting paid the same amount, for a private pay or a really good insurance or, a charity case, you're still doing the work. So in that sense, it's not a horrible thing that you're paid on wRVUs. You just have to watch out for these issues.
So, what percentage approximately of physician contracts are based or influenced in part by wRVUs?
I can't say this is off the hip from what I've seen, but I'd say probably 80%, 80 to 90%. A lot of them will have salaries and then we'll give you a productivity bonus. If you exceed this many wRVUs, we give you so much per wRVU. And some are really eat what you treat. And a lot of times after you've been there a few years, you're on eat what you treat. We're paying you. We may give you a draw. We'll call it a salary, but it's really a draw. We're going to pay you X amount, but we're going to true it up at the end of each quarter and at the end of each year. And if it turns out you weren't that productive, we're going to want some money back.
So, when you first introduce that concept of wRVUs, there are a variety of red flags and things to be careful of that physicians should be aware of. In general, when it comes to these wRVU targets, where do administrators, hospital systems, where do they get these numbers from in terms of the target percentile value?
Well, there are benchmarks. I mean, the ones I like are MGMA, but there are others out there, and some of them amalgamate several benchmarks. Sometimes I swear it's just they get a consultant in that says, "Hey, if you can get this many wRVUs out of the doctor, we're going to really, make a lot of money." I mean, some of them just don't seem to have any relationship to benchmarks at all. But in theory, they're based on some kind of benchmarking.
And in terms of the percentile that physicians should aim for, whether it's the 50th percentile, 75th percentile, how do they come up with those numbers? Are they just purely consultant based? Are they just pulling these numbers up from thin air? Or where are they getting
I
these numbers
think
from?
they are. One I see a lot is a 60th percentile. We expect you to be at the 60th percentile of productivity. And, I wouldn't have as much of a concern with that if you were being paid at the 60th percentile. It kind of seems fair that you'd be producing at the 60th percentile. But my concern is when we're paying you less than that, but we expect you to be producing at the 60th percentile.
So let's go through a couple scenarios and just tell us your advice if a physician finds themselves in that particular scenario. So let's say the target RVU is, say, the 60th percentile, and if a physician is producing under that for that year, tell us the type of risks that they may encounter if they're producing under the target RVU value.
Well, in a lot of cases, we'll figure it at, let's say we're paying you $100,000 and we expect 100 wRVUs, $1,000. Numbers are crazy, but $1,000 a wRVU. If you come in at 98, a lot of times we'll say we were paying you $1,000 per wRVU. You were too short. You owe us $2,000 in that scenario. So we'll say this is your salary, divide it by this number of wRVUs, and that's what we are going to charge you if you don't hit it.
And if a physician exceeds that target, would they get some sort of bonus based on how much they exceed that target by?
They should, yeah, they should get the same. And another thing I see is a lot of times they'll penalize you more for the wRVUs you don't make then you would think, hey, if you're getting $100 at wRVU, if you go over the threshold, you'll get, by one, you'll get $100. A lot of times, if you miss it, it's $100, but we'll give you $50 for every wRVU over the threshold. So there should be a match there. It should be, if you're penalized, you should get the same amount if you go over.
And then you also mentioned about the mismatch. If a physician produces above the target RVU but still getting paid below their production, how does that gray area, how does that mismatch sometimes get resolved?
Well, usually it doesn't. I mean, that's the kind of thing you
Mm,
have to negotiate in your contract. If you say, I will accept this much salary, and that salary is the median, and I accept this as my threshold, and that's the 60th percentile, that's where it is. If you come in at the 55th percentile of productivity or 59th percentile of productivity, you get your salary, and that's it. So a lot of it is just in your contract. What you're being paid should match up to the percentile productivity you're expected to produce.
Now, from the spectrum of contracts that you see, you mentioned some red flags that need to be negotiated specific to wRVUs when a physician first works for an employer. Just review for us like the top three concerns a physician should think about at the negotiating table when it relates to wRVUs.
Well, I think the first thing is it a reasonable threshold?
Hmm.
If you're paying me at the 50th percentile, then the threshold shouldn't be at the 60th. So is it a reasonable threshold? I always think the data service is very important and you should be able to confirm it. I think those are probably the three biggest things that you need to really focus in on.
And from your experience with physician contracts, how much wiggle room are there for those specific things that you talked about? Are they mostly included? Is it something that employers push back on? Just tell us the type of reactions that you get.
The one that I get the most pushback on is the mismatch between salary and productivity. A lot of times they say, well, our compensation committee has said this is what the other physicians are making, and we think the 60th percentile is right. So that's the one I get the biggest pushback on. Sometimes they'll say administratively, we just can't do that. Administratively, we know a wRVU when it hits the billing system. So we can't do it. I'm not going to argue whether it is. Confirmation usually is not a big deal. And if you think about it, if you're smart, if you're an employee and you're paying me on productivity, if you're smart, you're going to be keeping me apprised and saying, hey, here's where you are. You're behind. Maybe you should schedule more patients. Maybe you should do something. So the confirmation usually isn't such a big issue, but salary versus threshold is probably the biggest one that I see, and sometimes the hardest to negotiate.
So when it comes to these wRVU compensation systems, of course, it has to be accurate in terms of the measurement of the wRVUs. Should a physician independently keep track of their own wRVUs, or is it okay to rely on what the hospital comes up with?
I think it pays to keep track of your own, and I don't think it needs to be saw Susie Smith did this wRVUs, but I think just keeping your schedule and looking, if suddenly your production has dropped and you don't feel like you've been a lot less busy, then it's nice to have something to go back on, and even keeping your schedule a lot of times will remind you. Susie Smith had this complex procedure, is that reflected? I'll just check this one. Here's a big one. Was this one billed? So I think it does keep track. I hear there are some folks out there that are now developing do your own wRVU catches. I haven't spoken to anybody that's using it, but it seems like if it would be easy to do, it would be a nice thing to keep track of.
Now let's talk about another scenario, and that's of the new physician. A lot of times, new physicians get guaranteed salaries for the first 1 to 2 years, and then they switch over to a productivity-based wRVU system. So, in that situation, what should physicians look out for, especially new physicians coming out of residency who may not be familiar with any of this? What are some of the red flags they should look out for whenever they are looking at their first contract with a quote unquote guaranteed salary for the first couple years?
Well, first thing is you should still be eligible for productivity. The fact that you may not hit it and you're going to get your salary anyway, you should still be eligible for a productivity bonus. And it's the same thing. The productivity threshold should be pretty close to your compensation threshold. So I think that's one thing to look at. And again, if you're getting a productivity bonus, again, you want to be able to confirm it, all the things, we've talked about. The other thing you want to check is you want to make sure that it really is a guarantee. I've seen some that had a guaranteed salary, and but we the employer keep track of your wRVUs, and at the end of your salary was guaranteed, but you have X number deficit on the wRVUs, and that rolls into next quarter. So you're starting your first quarter on productivity in the hole because so it's important that if it's guaranteed, it means any deficit ends when the guarantee period ends. I've seen people really nailed by that one.
So let's zoom out a little bit. I think that a lot of productivity-based contracts, I've heard also some may be transitioning to more quality metrics influencing compensation, value-based metrics influencing the compensation. So what are you seeing in terms of that hybrid where productivity may be becoming less important and more of these quality metrics and value-based metrics coming in and influencing compensation instead?
I'm seeing it, but I see too many that say you've got 10% or even 20% potential quality compensation dependent on your hitting the wRVUs. And some of them are written, we want you to hit 5,000 wRVUs. If you hit 4,999 wRVUs, then the quality bonus is off the table. And if you think about that, I mean, that's maddening. Quality is quality. If you're doing good quality, you should get that bonus. It shouldn't be, oh yeah, but that's contingent on maintaining a certain productivity. That's to me the biggest trap you have to watch out for. I am seeing more and more quality compensation coming in.
But it sounds like to me, as of today, a lot of hospital systems still value productivity above all else.
They do. I mean, there is money, and the reason they're doing quality, let's not kid ourselves, is because the payers are incenting them on quality. It's not, I mean, I'd love to say, the hospital administrators just spend all their time worried about patient care, but I don't think that's true. They're compensated based on quality. But the bottom line, more times than not, is going to be based on physician productivity. So they're still very focused on that.
Today, we're speaking at the beginning of the new year. So, as it relates to physician contracts and especially productivity based metrics like we're talking about today, what kind of trends do you see in 2026 coming up when it comes to these physician contracts? Anything on the horizon, anything new on the horizon that physicians need to be aware of and look out for?
Nothing new. I think it's just becoming more critical as time goes on. 10 years ago, I'd see the occasional wRVU threshold. I would say even then, 90% of them were productivity based. If, we'll pay you your salary no matter what, but if you exceed this, then you'll get a bonus. Then it became pretty much you have to do this to earn it. And now I think the big trend is, as you said, the quality, and the quality should be an independent portion. It shouldn't be dependent on productivity. To a certain extent, they do kind of conflict with each other. But if you're compensating me for quality, compensate me for quality, not quality as long as you're also grinding out the wRVUs.
I think just as important as the wRVU is the dollar per wRVU that physicians
Yeah.
are compensated on. So tell us your thoughts about that because I see from the physician boards there's a pretty big regional variability when it comes to the dollar per wRVU. And that actually is going to be just as important as the RVU value number itself, right?
And yeah, absolutely. And there's benchmarks for that. This isn't the kind of thing where, you lick your finger and see which way the wind's blowing. There are benchmarks that says for this specialty, for this region, employed by a hospital or employed by a physician practice, this is the benchmark. And there has to be a really good explanation if they're under the benchmark, median benchmark.
Is there any negotiating wiggle room when it comes to that number, the dollar per wRVU number?
I have gotten it. It's hard because a lot of times that's our department gets X dollars per wRVU and we can't pay the other physicians less than we're paying you, so we have to do it. But it's certainly, sometimes you can do it and say, well, if you're doing that, then the threshold should be smaller. If you're paying less per wRVU, then you should have a proportionately smaller threshold.
We're talking to Dennis Hursh, healthcare attorney. Today's Kevin MD article is wRVU threshold risks in physician contracts. Dennis, as always, we'll end with some take-home messages that you want to leave with the Kevin MD audience.
Yeah, just be aware of it. So many people, I think, look at it and say, oh, they're paying me that's a good salary. I've looked around, that's a good salary. I've talked to other people. It may not really be a salary. You really have to look at it and make sure it's not, in fact, a draw against productivity. And if it is, you have to make sure that it's a reasonable productivity threshold that you're actually going to get paid, what they're seemingly promising to pay you.
Dennis, as always, thank you so much for sharing your perspective and insight, and thanks again for coming back on the show.
It's my pleasure.